I would now like to introduce our wonderful presenter, Dr. Rachel Fine. Dr. Fine is an assistant professor of psychology at Baylor College of Medicine. She is also a licensed psychologist working within the Autism Center at Texas Children's Hospital. Dr. Fine provides clinical assessments and treatment to patients within the Autism Center. In addition to specializing in the assessment and treatment of autism spectrum disorder, Dr. Fine specializes in working with preschool age populations and children with disruptive behaviors and utilizes evidence-based practices in working with these populations, including applied behavior analysis, parent management training, and culturally responsive assessment and treatment. She is trained to research reliability in the Autism Diagnostic Observation Schedule, 2nd edition, and is also a board-certified behavior analyst. Dr. Fine's research interests broadly surround ASD with an emphasis on parent management training for families of children with ASD and comorbid disruptive behaviors. We will be leaving time for questions after Dr. Fine's presentation. Please feel free to write your questions in the chat box at any time, and I will ask them on your behalf. We'll get to as many questions as possible. Now I would like to turn it over to Dr. Fine. Thank you, Dr. Fine.
Thank you. Thank you so much for joining me and having me here today. I'm going to go ahead and share my screen. All right. Can anyone give me a thumbs up if they can see this? Awesome. Thank y'all. Once again, thank y'all for having me. This is one of my favorite topics to talk about. It's, assessing girls can be so tricky. And I pose a lot of the questions and also a lot of the reasons why it can be so challenging, as well as some diagnostic considerations for your clinical practice. I am going to have a couple of discussion questions posed throughout. Don't worry, I'm not going to put anybody on the spot, but you can just answer in the chat if you're comfortable doing so, or if you're just wanting to take it all in, that's fine as well. So let's go ahead and get started. So before I go over objectives, or as well as the rest of the presentation, I want to just go over some terminology. You'll hear me refer to both sex and gender as I'm going through this presentation, sometimes interchangeably. And the reason for this is simply because I'm using the terminology that's referenced by the researchers that I'm citing. But obviously they are different. So for sex, it's the biological characteristics that categorize humans as male or female. And gender is socially constructed behavioral norms for each sex. So not the same, but sometimes they are used interchangeably. I'm also going to be shifting between using person first versus identity first language. Person first language oftentimes differentiates the person from their disability or their diagnosis of autism, whereas identity first language doesn't separate the two. Many autistic self-advocates have expressed preference for using identity first language, as they often feel like they cannot separate their identity or their diagnosis of autism as if it's taking on or off a hat. So also similar to what I had shared before, I'll be using the language interchangeably depending on which article I'm referencing. So in terms of objectives for today, by the end of the presentation, you'll be able to describe the most up-to-date sex ratio in autism. You'll be able to outline possible reasons for the discrepancy in diagnosis of autism between males and females. You'll also be able to identify common screening and diagnostic tools for autism, as well as list clinical considerations related to the assessment of females with suspected autism. You can't do a presentation on autism without explaining what autism is, but I know that y'all are familiar with this, so I will not be going over this in too much detail. But essentially, when we are diagnosing autism using the Diagnostic and Statistical Manual 5th edition, we're paying attention to two specific areas. So deficits also could be considered differences or difficulties in social interaction and social communication, as well as evidence of restricted interest and repetitive behaviors. And within each of these categories, to meet criteria for autism, you have to have all three deficits in social communication interaction. You only need to have 2 out of the 4 restricted interests and repetitive behaviors. And with autism, the symptoms have to be present in the early developmental period. So it's not something that you just develop as an adult. Things have to have been there the whole time. But what we do know is that behaviors may not fully manifest until social demands really exceed those limited capacities. So meaning an individual may have been able to kind of easily engage socially with others, but then once they became older or social situations became more complex, that's when they sort of hit their limit of being able to engage in sort of socially normed behavior. The other piece to keep in mind is that when speaking with autistic self-advocates and adults, we've learned that many individuals have also not just learned strategies, but have been taught strategies to essentially like mask some of their autistic traits, which has made it difficult for them to be officially diagnosed with autism. The other thing about autism, it has to cause clinically significant impairment. So it's not just, oh, this individual is a little bit quirky. It needs to be impacting them in some part of their life. So for instance, it might be social situations. It might be their quality of life at home. It could be within the educational setting. It could be not being able to hold down a job. But it's something that is causing difficulties for them. And then the symptoms or the traits of autism cannot be better explained by something like intellectual disability or global developmental delay, though it is quite common for individuals to meet criteria for both autism and or intellectual disability or global developmental delay. All right, so let's talk about the sex ratio in autism. So as you all know, the prevalence of autism has shifted with 1 in 44 children 8 years of age in the United States being identified as having autism, which is a shift from the previous CDC estimate of 1 in 54. But what we know remains the same is that autism is 4 times more common among males than among females. And some researchers have actually found that it's 2 times more common in males with moderate to severe intellectual disability, 6 times more common in males with normative IQ, and then 9 to 10 times more common in males with quote unquote high functioning autism, also previously known as Asperger's. So I am going to pose a question to the group, so feel free to write it out in the chat. Why do you think that girls are less likely than boys to be identified with autism? Go over it in just a few minutes, but I would love to hear from folks what y'all's thoughts are or what your experiences have been. Let's see. Okay, somebody raised their hand, but I don't have the
Can you
ability.
hear me?
Yes, I can.
It says the chat is disabled.
Oh, okay. So sorry. Okay, well, you're welcome to share if you have an idea now. I'm putting
My
you on.
thought was just that the symptoms there's different type of symptom presentation, and boys are more likely to have more of the traditional externalizing pieces that people notice.
Yeah, so it might be related to more kind of classic, people have a classic idea or an idea that individuals might engage in more classic presentations of traits of autism. Absolutely. Thank you for sharing that. Anybody else? And I'm hoping our moderators can enable the chat. Okay, it's enabled now. Anybody else want to add anything? Right, so females may be given more socialization and have higher social expectations and directives in place when growing up. That's a great example. Girls tend to mask symptoms more often. So especially individuals that might have some like higher cognitive abilities or more, expressive language skills. Yeah, so the impact of symptoms for girls, they might be more significant once they're older. These are really, really good examples. More of that social awareness. Y'all are definitely like hitting the nail on the head. The internalizing piece. So yes, so many girls often display more like internalizing disorders, which might overshadow things. Perfect. Thank y'all so much for contributing. Sorry about the chat piece. All right, so I'm going to move on. All right, so there is recent research really that challenges the findings that I've shared on the 2 slides ago that really indicate lower sex ratios for the autism spectrum than those previously observed. So why is that? Well, there's several possible explanations as I have listed here. And one hypothesis suggests that there are perceived barriers to diagnosis that really contribute to this discrepancy, such as barriers to just accessing an assessment in general. There's also likely gender bias built into the diagnostic assessment process. Another hypothesis argues that there's something just inherent in being female that quote unquote protects females from the likelihood of developing autism. Another hypothesis suggests that symptoms of females, so symptoms of autism within females, really don't fully manifest until an individual hits adolescence. And one of the most widely accepted theories is that there's this idea that females just are more likely to develop autism than we currently estimate, but perhaps they just manifest their behaviors or their traits in different ways. And so it makes it less likely for clinicians to pick it up. There's also this idea of higher rates of gender diversity within the autism population, and I plan to go through each of these. So Estrin and colleagues in 2020, they did this really excellent systematic review looking at what those barriers to being referred for an assessment might be, and they identified 2 categories. So symptoms and behavior, and then perceived barriers to diagnosis. And I don't want to spend too much time talking about the symptoms and behaviors because we're going to cover that later on in the presentation, but I did want to highlight a couple of pieces that I think are important. So what they found is that females with lower IQ or behavioral difficulties were more likely to receive a diagnosis than females with higher IQ or minimal to no behavior difficulties. And this just isn't true for males. So what I mean by that is even when males have, higher IQ or limited or minimal behavioral difficulties, they're still getting referred for autism evaluations. So what this means is that females literally require more additional difficulties, even with similar levels of autistic traits to their male counterparts, to improve their chances of being referred for an autism assessment. The area that I want to focus on for this specific slide is perceived barriers to diagnosis and how autism is often considered a boy's disorder. And so with regard to parental concerns down below, studies have shown that parental reports of restricted interest in repetitive behaviors, also known as RRBs, they were less predictive of a diagnosis of autism compared to males. So for instance, say that you have an 8-year-old boy, he's super interested in collecting maps. This specific interest or behavior might be worrisome to a family, and it might signal, hey, he's really interested in this. This seems a little bit different compared to other boys. I think that we need to get this checked out. Whereas if a girl had a similar interest, parents might say, well, they're keeping to themselves, they're being quiet, they're not causing trouble. There might be some gender bias related to parental concerns. So they might be less likely to refer for an evaluation or ask, or be concerned or talk to their pediatrician about it. Further, parents were less concerned about social problems and were more concerned about like emotional or behavioral problems in females than later went on to receive a diagnosis. Another area of concern is that when the parents have expressed concern about just the lack of information, like when they start Googling or, reading articles or books, oftentimes they're seeing presentations related to boys and there's really no mention of girls. And so they think, well, this doesn't explain what's happening to my daughter or to my kid. Maybe it's not autism, or autism doesn't even cross their mind because there's no representation there. There's also clinician bias. And so clinicians evaluating girls with complex profiles are more likely to exclude autism as a diagnostic consideration, especially when there's other diagnoses potentially on the table. And they've also found that there are increased social expectations just being placed on females, which was mentioned in the chat as well. And so there's also adult perception of gender roles. So, you know, what we bring to the table with the diagnostic process. So what our expectations of how girls and boys are supposed to behave and supposed to act and supposed to be interested in can definitely influence our perception of the autism evaluation process. And compensatory behaviors are mentioned here, and we're going to wait to talk about that a little bit later on. So we've talked about barriers to accessing an evaluation, but what about the barriers created by the diagnostic screeners and tools themselves? So I've included a table here that was actually created by a previous colleague, Dr. Cash, that she had put together for a chapter of a book I was editing. And I really love this because it goes over all of, you know, some of the big measures that are used, as well as the age range, time of administration. And I have this here because there is substantial evidence suggesting that diagnostic tools are just less likely to identify females when we're trying to figure out if they have autism or not. In my own practice, I consistently use the ADOS, also known as the Autism Diagnostic Observation Schedule, as well as the SRS, the Social Responsiveness Scale, second edition. And my developmental pediatrician colleagues, they consistently use the Childhood Autism Rating Scale, or the CARS 2. And the thing that all of these tools have in common is that their validation studies have been assessed with excessively homogeneous populations, or homogeneous samples, meaning that they're generally composed of, you know, white cisgender men from, you know, typically like American or like Western Europe or like Australian groups. And so they're essentially leaving out a big part of the sample or population, which is, you know, girls and women. And so it's important to reflect on that and think about, like, what are our tools actually measuring? And so how does this actually play out into practice? I'm not going to go over all of the research, but I do want to highlight a few pieces that I think are relevant for your practice, especially if you're assessing for autism in children and adolescents and adults as well. So Tillman and colleagues, they found that parents reported a lesser level of early childhood restricted interest repetitive behaviors in females compared to males. However, there were no differences in social communication and interaction at this age of presentation. And then other researchers found that scores of males with autism were significantly higher than the ones obtained in females. For the undiagnosed participants, the scores did not present significant differences. And for the CARS 2, researchers found that boys scored significantly higher on domains like body use of objects, or activity level, while girls scored higher on aspects of sensory sensitivity, so things like taste, smell, and touch. And there was a really interesting study done where the SRS was used as kind of just general autism screening tool at a mental health center for children and adolescents. And they observed that the male-female ratio among the subjects diagnosed was 2.6 to 1. However, at a later confirmed diagnosis as part of a comprehensive psychological evaluation using other tools, the ratio varied significantly at 3.7 to 1, meaning they tested quote unquote positive for autism at the screener, which is, you know, the job of a screening tool. But when they went on to go through the evaluation, they didn't meet criteria for autism using like the ADOS or the ADIR. But later on, they did end up meeting criteria for autism at a later age. Something else to keep in mind is that autistic females tend to display more severe symptoms than autistic males when compared to typically developing males when using the SRS. And lastly, about the SRS, I don't want to forget that it's the only tool that, compared to the ones that I've shared thus far, that actually compares a patient to their respective sex. So like the female patient that's being assessed for autism, their behaviors are compared to neurotypical females, and same thing for males. And going back to this, something I want to highlight as well is that it's not to say don't use these tools, they're not good, absolutely not. The purpose is just being mindful of what are the limitations, and if there's a limitation of one tool, perhaps we need to be adding on a second one or gathering information from a different source to ensure that we're coming to an accurate diagnosis and developing accurate impressions. So now I want to talk briefly about the female protective effect. So we've identified issues with the diagnostic process, but what about biology? And this is where this specific theory comes into play. So the idea behind this hypothesis is that females are biologically protected from autistic characteristics relative to males. And this protective factor results in reduced behavioral expression of autistic characteristics when the genetic risk of autism is equivalent to that of males. And essentially what this means is that for a female with autism to get diagnosed with, for a female to get diagnosed with autism, they have to have a greater genetic load than males in order to express the same level of characteristics, meaning there has to be perhaps like a more significant history of autism in their family for them to go on to meet criteria. But one of the issues with this theory is the research is assuming that the estimates, the prevalence estimates are correct. And the second issue is that we're also assuming all the diagnostic tools that we're using are equally reliable and valid with both males and females when it comes to assessing them for autism. And then according to the adolescent emergence hypothesis, compared to males, autistic social traits, also known as ASTs in females, are more likely to become evident in adolescence rather than childhood. And I have a screenshot of a self-advocate from TikTok who often talks about kind of diagnosis later in life and also just girls with autism. And in case you didn't realize, TikTok is the new WebMD for adolescents and young adults. So if you don't have an account, you probably need one so that you know what everybody's talking about. But going back to the adolescent emergence hypothesis, the idea is based on reports that autistic women, from their experiences, that their social and communication difficulties really only became more apparent or more overt once they reached adolescence. And so when social situations became much more complex, they were starting to notice like, wow, this is a lot harder. This is more difficult for me to do, or I'm receiving more feedback from others that I'm not able to get along with people. My relationships are kind of deteriorating, or I'm not able to really form connections and relationships with other people. And so Mandy and colleagues found that by 16 years of age, females had higher autistic social traits than they had when they were much younger, so at 7 years of age. Also, females no longer had lower autistic social traits compared to males. In fact, males and females were at equal likelihood of clinically severe levels of autistic social traits. And then another explanation for the underdiagnosis of females is that their presentation of autism is just qualitatively different to the typical male presentation of autism. So this female autism phenotype or behavioral expression of autism, more common in females, it really represents similar underlying autistic characteristics as those described in current diagnostic criteria. So what this means is we don't need to throw out the current diagnostic criteria based on the DSM-5, but we need to really expand our understanding of and recognition of traits that fit the different criteria, and that it may not look like the stereotypical or classic presentation that we often see in males with autism. And then females may also express other additional behaviors or characteristics that are not typically included in the autism diagnostic criteria. And some of these We're going to go through all of this, but some of these specifically talk about like internalizing problems and also camouflaging symptoms. So more research has been done to really suggest that the nature of difficulties with social relationships, it might differ between girls and boys. Females with autism, they tend to have higher levels of social motivation compared to males and similar levels to neurotypical females. They tend to have less difficulties with initiating friendships, but they might find it more difficult to maintain friendships. They also may have a harder time coping with conflict in social relationships. And so, my light goes off. And so one of the things that I often think about is once children or tweens or teenagers start having cell phones and have that ability to like text with one another, you know, it might be easy to say, initiate a conversation and say like, hey, like, what are you up to? And then the person responds. But then what I often see is that the autistic child or tween or teen, they just keep texting. So they might text the same thing multiple times in a row, or they aren't able to read the other individual's cues like, hey, like maybe they're busy, maybe they can't respond immediately, or that person is no longer interested. And though autism in males and though autistic males and females reported fewer friendship behaviors than typically developing males and females, females with autism reported friendship behaviors most similar to typically developing male peers, which I found to be very interesting. But still, when we think about social relationship, the research is still pretty mixed when it comes to early play skills of girls with autism. So although girls with autism engage in more pretend play than boys with autism, their pretend play often is more repetitive, it lacks reciprocity. And so I think about a patient that I saw not too long ago. She engaged in this like a beautiful pretend play sequence of, you know, taking care of a baby. So she like picked up the baby doll, she fed it, she gave it a drink, she patted it, she rocked it to sleep, she answered the phone. She said like something to the effect of like, I can't talk to you right now, I'm busy, and like hung up the phone. And it was like very cute. But then she kept doing it over and over again. So she did that same play sequence about 5 times in a row, same script, same intonation. And when I tried to join her or even tried to switch it up a little bit, I either received no response or I was met with mild frustration and annoyance. And she just continued to engage in that cycle, which I think is really reflective of what the research shows. And then girls with autism often engage in toys replicating traditional gender differences, so like dolls, domestic items, but it tends to be at lower rates than typically developing girls. And then toy choices tend to be aligned more closely between females with and without a diagnosis of autism than with males with autism. And then there was a study that was done that looked at children's play at recess, which I thought this was so fascinating. They found that even when engaged in solitary play, girls with autism, they tend to stay physically near their female peers, even when they're kind of weaving in and out of activities, but it looks appropriate. But with boys, because boys tend to play games that are more like groups and have like rules, so more like sports activities, it's very obvious when a boy with autism perhaps is not really part of the group or it's not really joining in. And so sometimes it's just the differences in how girls and boys are playing on the playground can make a difference in how readily apparent some of their traits are. And then, you know, the female autism phenotype focuses on restricted interests and repetitive behaviors. There's been a lot of research related to RBs of males and females, but results are pretty mixed. So on one hand, some researchers have found lower rates of RBs in females compared to males. However, females may have more compulsive self-injurious behaviors. They may have more insistence on sameness, or things just might be more repetitive. So the results are mixed here. But what they've also found is that like highly focused or special interests may be different from males and not viewed as atypical or problematic. So they might be more interested in age and gender appropriate topics or themes, and that based on some of the research that's been done, their interests most commonly fell into the category of like TV, so like movies, listening to music, YouTube videos, tablet watching, or like this theme of psychology, so like relationships, emotions, imagination, live action role play. And I love this table here because it breaks it down into primary interests. So for instance, on the left hand side, you have examples of autistic boy and girls and the things that they might be interested in. And then on the right hand side, you have examples of typically developing boy and girl interest categories, which I find falls really in line with what I see in my own practice, which is many of the girls are super interested in things like My Little Pony or LOL Surprise dolls, drawing, painting, things like that. And this figure here shows something similar, just a different visual presentation of what it looks like. All right, and so moving on to internalizing problems, like another aspect of the female autism phenotype is related to this idea of internalizing problems. And when discussing it for research purposes, internalizing problems isn't just related to like depression and anxiety, but it's really sort of any inward expression of emotional difficulties. So it's also related to, co-occurring self-harming as well as eating disorders. And related to this, males are more likely to have co-occurring externalizing disorders, which I think somebody else mentioned in the chat earlier. And the problem with this is that it has a pretty huge impact on identification of females with autism. So one issue is diagnostic overshadowing. So when you're seeing more severe internalizing disorders, like, significant anxiety, depression, self-harming, eating disorders, this may mask underlying autistic traits. It also perpetuates the gender bias in autism symptom recognition and also referral. So people might say, we need to focus on this, the self-harming behavior, or we need to focus on the anxiety when like perhaps that's not the root issue that needs to be addressed. Like perhaps we also need to be assessing them for autism as well. Like it's not necessarily less important than some of those other pieces. And then camouflaging is thought to be more prevalent in women than men, though it's still something that men can do. So it's really important to understand what camouflaging is and how it impacts the functioning of girls and women with autism, as well as the assessment for autism in women. And so the term social camouflaging was first coined by Lorna Wing in 1981, and it's defined as the use of strategies by autistic people to minimize the visibility of their autism during social situations. And based on this, Mandy and colleagues came up with the female compensation hypothesis, which essentially says that females with autistic social traits, or ASTs, they learn over time to compensate for their social communication difficulties more effectively than males with high autistic social traits. And so research suggests that the main reason for doing this is really to avoid social stress. And so there's a quote here from some of the qualitative research that says, I wanted to avoid the bullying mostly. And although there's certainly benefits to camouflaging, like helping establish relationships, hold down employment, pursue education, there's a lot of costs. So it can delay or prevent a diagnosis. It's also associated with pretty significant mental health challenges. So there are some advocates who are autistic who have actually shared that it's been traumatic for them to, feel the need to like camouflage or mask their symptoms, or it's caused them to have be not just emotionally vulnerable, but physically vulnerable in relationships because they, either were overtly told or indirectly told to camouflage and mask to be successful, but then they start kind of like losing part of their identity and not having autonomy over their like feelings and body, which is very dangerous. And then I wanted to go over just some different pieces of camouflaging. So you have 3 different areas here. So compensation, which is finding ways around things that are naturally difficult. An example might be an individual forcing themselves to make eye contact with someone. Masking is actually hiding parts of your autism. So maybe you have somebody is really interested in, horses, and they really want to talk about it, but they don't talk about it and pretend that they're not really interested in it because others aren't. And then there's assimilation. So trying to fit in with everyone else so that people don't notice you as different. And so an example that they have here is talking to a stranger in a store, even if you don't want to. And then the last piece of research I want to focus on before I talk about a case example to really drive home the point of the female autism phenotype, gender bias, as well as clinician bias. There's this really lovely figure describing all of the things. And so Whitlock and colleagues conducted a study with elementary education staff. They were presented with 4 written vignettes, and each vignette described autism features in males and females. And they were broken up into 4 categories. So the first vignette was a classic female phenotype, and they were given a traditionally female name, Chloe. Then that same vignette was given a traditionally male name, Jack. Then there was a male phenotype vignette that was given either the name Chloe or Jack. And as you can see here, that they were more likely to identify autism when there was the classic male phenotype, when there was a male name, and then less likely to identify autism with a female phenotype and a female name. And you can see that there's some differences too in between, but I think this is a really nice example of all of the pieces related to the female autism phenotype and gender bias, even just based on names alone. So to illustrate how some of these theories all relate to one another, I wanted to present an assessment case to you all. We're going to call her Fiona. So Fiona is a 10-year, 8-month-old white female. She was referred to psychology by pediatric neurology due to suspected autism spectrum disorder. She's currently being treated by neurology due to her history of tics and Tourette's. So starting at 5 years of age, she developed some repetitive lateral neck flexion movements in first grade. Since that time, she had sort of waxing and waning movements, including blinking, shoulder shrugging, lateral head turning, arm extension, leg extension, vocalizations such as damn, some squeaking noises. She isn't able to describe the urge, but she is able to hold the movements in for brief periods of time. And she's very bothered by these things. Like, she knows that they make her stand out. She sees people looking at her, making comments. It's very distressing. She also has a long-standing history of learning disability, explosive behaviors, low frustration tolerance, and difficulty handling both minor and major disappointments. Her mom reported a history of things like yelling, screaming, biting, scratching herself, slamming doors, melting down, which have improved through her parents really sticking with boundaries, receiving some like parent training, which they found to be very helpful. So while the behaviors occur less frequently and are less intense, they're still happening. So she continues to yell, she continues to curse, raise her voice when upset. She also has significant difficulties with inattention, hyperactivity, impulsivity across settings, so both home and school. She also has a history of some obsessive thoughts and symptoms of anxiety, including needing to tell her mom something bad that she's done every single day when she gets off the bus, telling her mom that she has masturbated before bed. So as soon as she does it, she goes and has to tell her mom. And then expressing significant concerns regarding her mom's well-being. So just constantly checking to make sure she's okay. And going to defend her and try and protect her if she feels like her mom has been wronged in some way. She currently takes flufenazine for tics, Focalin for ADHD, and Luvox for OCD-like symptoms. And then really, and despite of these improvements for her tics and ADHD, like the medication has really worked beautifully, she still has these obsessive thoughts. She still has difficulties interacting with same age peers. She's been evaluated multiple times by previous providers or other providers in the community since she was 2 years old. Autism has always been on the table as a diagnostic consideration. but her symptoms of ADHD and tics have always gotten in the way. So it's really interfered with the providers being able to either complete the evaluation, because many times they had to be discontinued, or for the provider to come to an endpoint of deciding yes or no, does this person have autism? She's also always been identified as being a quote unquote sophisticated only child, so easily interacting with adults, having no difficulties connecting in that way. And so the pediatric neurologist basically referred over and said, look, there's some OCD stuff. Not quite sure if that's what it is, if it's autism, but she needs a comprehensive evaluation. So I want to pause for a moment and give folks a chance to write in the chat, like, what are your impressions so far and what else do you want to know? It's a great point. So insights into her peer relationships. It's a really great point. Like, what's her understanding of what a friend is? Yeah, I would agree. Observing peer interactions would be really helpful. So like, what do those look like? Anything else? Her developmental history. Previous measures have been used in previous evaluations. Absolutely. Those are all great questions, or great comments, I mean. So thank you. I'm going to move on. All right. So as part of our evaluations, we complete a very thorough diagnostic interview. We complete the ADOS-2, we do cognitive and academic testing, we use the SRS, the BASC, the ABAS, we get teacher report, parent report, and we're also fortunate because we work in a hospital setting where we have an electronic medical record. So we have her previous school reports, we have all of the history from her neurologist that she's been working with very closely over the years. But for the purposes of today and time, what I want to do is I want to review the ASD symptomatology based on parent report, teacher report, the ADOS and SRS, and then just general observations during testing. All right, so going through, so looking first at social communication and interaction, some of the things that mom reported and what we also observed, she asked really personal questions. So she had shared an example of when her neighbor was checking the mail, she came out and just randomly asked her, when you take a shower, do you ever get a hair in your vagina? And then during testing, while we were doing the break activity, she randomly looked up at me and goes, what's your husband's favorite football team? So she had no idea if I was married, if I had a husband, do we like football? It was very specific. And then she can have back and forth conversations, but it only can occur with an adult who's pretty flexible with her and kind of lets her take the lead. And she also talks at others. And she's very empathic, but she often misinterprets interactions and responds in like an overly dramatic manner. So for instance, her mom, she was on the playground. She saw her mom try to come through the gate, but she didn't have her badge. And the teacher didn't scold the mother, but basically said, hey, like, in the future, you need to have your badge. And she misinterpreted that as her mom getting in trouble. And she basically started screaming at the teacher, like, don't yell at my mom, like, she's fine, that sort of thing. And then she does initially display appropriate eye contact, but it fades over an interaction. It often involves her avoiding eye contact or darting her eyes around the room. And while she does use like gestures and facial expression, she doesn't seem to respond appropriately to others' use of nonverbal communication. So she doesn't really understand like when a person's sort of backing away or no longer interested in her. She, as I mentioned, she misinterprets social situations, and similar to what I mentioned earlier, she will see her parents having kind of not like a heated argument, but more kind of like an animated discussion. They both are very like passionate about their work and they're talking about it, and she'll interpret it as they're fighting, and she'll start crying and screaming when they're maybe just like talking animatedly. She also displays limited insight. So she struggled with being able to explain like what a friend is, the difference between a friend and a classmate. She also doesn't adjust behavior to different contexts. So she's an eater. So it's like she'll eat like a week's worth of snacks that's in her pantry, but then she also does the same thing when she goes over to other people's homes. Like she'll immediately just go into their pantry and just start eating everything. Her mother typically is the one that organizes play dates, and her mom shared that she has pretty limited motivation to see others. Like she's fine if they're at her house, but she shared this really poignant example of Fiona had a peer over, and her mom went to go check on them, and she found the peer just kind of playing alone in the playroom, and she was like, "Where's Fiona?" And she's like, "I don't know, she disappeared." And she looks out the window, and Fiona had gone in their backyard and just started playing on their playscape without letting anybody know. And her mother also indicated she's typically found playing alone when she's at a birthday party, and her teachers reported that she tends to play alone and sit by herself at school. And then in terms of RRBs, she uses repetitive phrases. They're not super unusual, but they're repetitive, and she uses them at a high frequency. So she uses the word actually, and she frequently says sorry about that, which, as if you're thinking about gender bias, it's very common for women to apologize for no reason at all. And I think that's an example of something that is perpetuated here. She also asks questions using the same like beginning. So for instance, during testing, she is super charming. So she would randomly say like, "Has anyone ever," and she would use that same beginning, like, "Has anyone ever vomited here?" Or, "What would you do if the hospital caught on fire?" And she's super fun to talk to, but then you realize like it's very repetitive. She also uses some overly formal and scripted language. So she randomly, while we were like drawing a family during a break activity, she goes, I can't have a baby at 18, as if like she was repeating something that she heard. Or East Coast oysters are just simply the best, which, I don't disagree, but just a little bit unusual for her to be saying that kind of at random. And then in terms of insistence on sameness, lots of like literal thinking and interpretation. So during the telemedicine visit, I asked her during that visit, like, "Oh, who lives with you?" And it was just her mom sitting next to her. And she goes, "Well, I live with my mom." And I go, "Oh," I was like, "I thought that your dad lived there also." And she looks around the room and she was like, "Well, he's not here right now." And I was like, "Oh, okay, but he does live there." And she's like, "Yeah." She also, her family and her teachers endure struggles with transitions, changes in routine, and changes to her environment, to the point where they've essentially put so many accommodations in place. So she has visual supports at home, she has visual supports at school. They keep her routine as consistent as possible. She uses timers throughout the day to help support her, and they've been successful, so it's worked for her. She also goes through phases of highly focused interest. So like right now, she's very interested in surgeries and will watch YouTube videos of surgeries being performed. Previously, she was very interested in the school nurse and was obsessed with her and would want to go visit her and ask her lots of questions. She also carries around a bag with very specific items, which she did on the day of testing, and then lots of sticky attention during testing. So meaning like, it's not like she talked about surgery during our testing visit, but she would her attention would glom on to something random in the room. So like in the room, it was the thermostat, and she would frequently talk about that, or the prize box. Like she brought that up, and I did like a tally mark of how many times she did, and it was about like 21 times she brought that up. And then she seeks out sensory input and sensory, she has sensory aversions as well. So based on, and obviously I'm not going over all of the testing, but based on the ASD traits, the history and the observations were very compelling. And so we did diagnose autism. We kept the ADHD and Tourette's by history. She was on medication, it was working. She was, as I mentioned previously, diagnosed with learning disability by the school. We had the report, and our testing also reflected that as well. We still provided a rule out for OCD. And the reason why we did that was because even though some of the behaviors that were described could be explained by her RRVs, the need to tell her mom something bad she did when she got off the bus, and then her behavior in the evening time, it just had an OC quality. And so we ended up referring for CBT. And I'm so glad we did, because the psychologist that specializes in OCD said, we're not going to give a formal diagnosis of OCD, but we have enough OC-like behaviors that warrant treatment, but we can treat this so it doesn't turn into OCD. And we also made some recommendations for the family about like psychoeducation, executive functioning, social skills, and ABA consultation. So I'm looking at time. I want to just hit gender diversity as well. So up until this point, I've been citing research that's really taken this very binary view of gender, and that's also part of the problem. So when we think about gender diversity, like within the context of autism, we need to think about like, what are the rates of gender diverse behavior within autism within gender clinics. And so I want to share some of the data. So there's a higher incidence of autism that was found in a sample of children referred to a gender identity clinic for management of their gender dysphoria. And when asked questions on the CBCL, responses to the item wishes to be the opposite sex was 7.6 times more common in the autism group. When we think about rates of autism diagnoses, they're between 5.5 to 26% in those attending gender clinics, which is a big range. And then 6.5% of autistic adolescents and 11.4% of autistic adults reported a wish to be the opposite sex, compared with 3% of adolescents and 5% of adults among the controls. So I think we can all agree that based on the research just shared, that there's higher rates of gender diversity within the autism population. So what does it actually mean to be autistic and gender diverse? Well, Strang and colleagues conducted a study where they followed 22 autistic gender diverse adolescents for nearly 2 years. And they found that most autistic adolescents had gender diverse inclinations early in childhood, but they were reluctant to express their identity. This could be because they were worried about bias and harassment. And yet it seemed urgent to most of them to address their gender needs. And then respondents also indicated they had trouble with complexities of gender affirmation, so previously referred to as gender transition. So this was related to self-advocating for their gender needs, to filling out forms, to making it to multiple medical appointments. It's just a lot. And then because of their social differences, some participants were unable to really tell how other people viewed their gender. So that was also distressing. And then 1/3 of the participants shared that they had questioned other people had questioned their gender diversity because they are autistic. So for example, people told them that their gender diversity was simply an obsession rather than a real experience, or that experience was a feature of autism itself, which was incredibly distressing. And I'll be totally honest, I've been guilty of that, where I thought this is related to traits of autism and haven't fully explored that. And I've learned, I'm moving on, I'm doing better. But that's something I'm going to encourage other folks to do better about as well. And then what else are we missing? So I've presented some different questions here. I'm not going to spend too much time on, but I think one of the things that we need to think about is also just like gender roles in different cultures. Are we also focusing on autism through this lens of like ableism and or ability bias? And I'll say, yeah, I mean, for the DSM, it's deficits in, when we should probably be reframing it to differences or difficulties. And then also thinking about how these things fit within the neurodiversity paradigm. And so lastly, I want to focus on considerations. So when we're thinking about identification of girls with autism, when you're doing an evaluation, you want to make sure to ask about what are the family's perceptions of barriers to accessing an assessment. Because I think this is also really telling. Like I think about Fiona and I think about that family had no difficulty accessing assessments, but they had also shared their perception of what autism was not necessarily accurate. You also want to pay attention to maintenance of social relationships. So as I mentioned, not just can they form a friendship, but can they keep a friendship? And then what's their ability to manage their behavior across settings? So I think about the patients that mask. I have a patient who, and I can't remember if I shared this already, but I have a patient who was able to keep it together, would sit on their hands during school, would force themselves to make eye contact, but then would just lose it as soon as they got home because it was so distressing for them to do those things. And so it resulted in a lot of school refusal and it was super challenging for them. Or I think about, like Fiona, for instance, who's eating everybody's food when she goes to another person's house. And that perhaps we need to be looking at social skills relative to same age non-autistic females, rather than comparing their behaviors to autistic males and whether or not they have interest in things like trains and cars and lining blocks up. Ask about specific interests and the level of intensity of it, because even when things are perhaps gender normed or age appropriate, it's really that intensity of it and how all encompassing it can be. And also sticky attention, right? So as I mentioned earlier, like Fiona was not talking about her surgeries in the assessment, probably because she knows that it wasn't appropriate to do that. But she did have what we call sticky attention, which is, that ability to kind of focus on something kind of random and continually come back to it. Teacher perception is huge. So many of y'all are working in schools, I imagine. And so getting that teacher perspective of what are they seeing on the playground? How are they seeing those interactions with peers? And then that change in presentation of symptoms over time is also really important. So knowing that, yes, there may have been difficulties when they were younger, but what exactly did they look like and how have they evolved over time? Include other measures. So obviously I use the ADOS. I think it's great. I do not use the ADIR, but I know many that do and find it to be really helpful. But what are those limitations of them and what else should we be using? And then don't let additional diagnoses overshadow possible autism. I'm not saying ignore those other ones, but we can address both things at the same time. And then avoid solely considering binary concepts of sex and gender. I think this is huge. And I think sometimes it's impossible to not kind of based on our diagnostic tools, but we need to definitely expand our minds. And then be mindful of theories such as the female autism phenotype, but also listening to those lived experiences of autistic self-advocates and their families is so crucial. So I know this was a lot of information. I really appreciate your time. I want to make sure to give time for questions. So thank you.
Wonderful. Thank you, Dr. Fine. I thoroughly enjoyed and learned a lot from your presentation, and I'm sure others did as well. So one of the questions that was asked was, what about the MIGDUS? And when you were talking about diagnostic tools for ASD, and I know you just commented on other potential tools as well. So they're wondering about that tool regarding diagnostic purposes.
Yeah, I think, I'll be honest, I don't have familiarity with it. I've used it briefly, like earlier on in training. And what I've heard from other clinicians is that it has a lot of clinical utility. I just don't know about the research supporting it. And a lot of the articles that I was looking at too just didn't reference it, to be honest. But it's not to say that it's not valuable and could be helpful. If other people have experiences with it, I encourage y'all to chime in on the chat too about that. Another tool that I know other people have used, like speech and language pathologists, was like a social thinking assessment that's not projective, but it's very much like, showing pictures of family and having children like infer like what those relationships are among family members. And I think that can be certainly helpful for like a more unstructured assessment.
Wonderful. So another question was, since it presents differently in girls, what symptoms should we pay more attention to in early childhood?
Yeah, so I think that it's one of those things where it's not just one thing, right? You're looking at a constellation of symptoms or traits. But I would say, like, I think there is this idea like, oh, girls are just more social than boys are, which, might be true. But I think that we need to pay more attention to that and kind of tease that apart a little bit more. So like I gave that example of like the repetitive play, and it's not just like, oh, they can play, but can they interact? Like, is there reciprocity there? Is there interest? And is that play also a repetitive behavior? Like, can it kind of hit different criterion? Because I think sometimes providers and trainees will look at the criterion in this kind of inflexible way when like one specific behavior can actually kind of hit different points. So I would encourage folks to do that as well. That's a great question.
Great. Another one that came through the chat is, knowing there's a lot of gender diversity, is it helpful to use an assessment with gender norms to try to not be comparing girls to boys with autism as much and maybe catch it more?
Yeah, I mean, I think that's a great question. Honestly, I don't know the answer to it. I think that's where, yes, the tools should be there to help inform what we do, but I also think that looking at the behaviors for what they are. So I'm trying to think of an example. So for instance, like I used to work in the gender medicine clinic here at at Texas Children's. And so even though the goal was not assessing for autism, it often came through. And so we were seeing girls that parents had described as, tomboys or engaging in more kind of gender nonconforming behavior. And so in those situations, like we're also just looking more on like parent report and what we're observing in the room, and what those interactions feel like, right? Because, an individual could identify as a different gender, but like it's also what behaviors are they exhibiting? So I think it's important to consider those things, but we also don't want to get too hung up on it in the sense that it stops us from like recognizing traits of autism, if that makes sense. Because, we want to still have the diagnostic criteria in our minds and paying attention to like what fits within some of these different criteria, whether they are male or female or identify as a boy or a girl.
Great, thank you. There's one last question in the chat, so let's maybe finish off with that question, just keeping an eye on time. Are there any social skills groups or group therapy programs you would recommend for middle school girls with ASD?
Yeah, that's a really great question. So we're located in, I'm located in Houston in Texas, and Texas isn't great on resources here, but we typically recommend like a lot of the social thinking groups, I think, can be really helpful. Like we have a program here in town called like social motion skills, but I think the main thing is just, I don't know if I think what's tricky is to the earlier question about, should we be like norming things should we like get rid of gender norms? I think it's just finding groups where the patients can be with their people. So where they feel comfortable, where they feel, validated, where, they're not being taught to like mask or do anything that's like distressing, but still like giving them options of what to do. So I think that like, that's what's kind of hard about social skills groups, is because a lot of it is teaching kids to like mask and do things that are challenging. But I think we also need to integrate kids into just regular settings and also teach their neurotypical counterparts to also learn better social skills of being like inclusive and, recognizing people might look or act a little bit differently than they do. So I think it's kind of like a yes and a no. So yes, social skills, but I think they need to be like a very specific types of groups, and it's going to be so individualized as well.
Wonderful. Thank you again, Dr. Fine, and also thank you all for attending this APA Division 16 webinar. I hope you all have a great weekend.
Thank you, everyone.